Hi, my name is Sarah Gimbel. I'm an associate professor at the University of Washington, and today I'll be talking to you about applying the Consolidated Framework for Implementation Research, or the CFIR, to evaluation, tool development, and analysis. And I'll be using, in particular, a case study of an R01, which I lead, called Optimizing Hypertension Care for People Living with HIV in Mozambique. So implementation science frameworks help guide standardized research. And in general, we consider theories, frameworks, and models as those types of frameworks that we use. Theories help explain the causal mechanisms of implementation. Frameworks help us understand factors that influence implementation outcomes, and models guide the process of translating evidence into practice. Frameworks in particular help systematically address the no-do gap and help guide results for scaling up the implementation of evidence-based interventions. Strategic action planning models for intervention development, management, and evaluation can enhance the interpretability and ensure implementation strategies are included in the next phase. Generally, theoretical approaches that are used in implementation science include guiding those that guide the process of translating research into practice, those that explain what influences implementation outcomes, and those which evaluate implementation. And today we're going to be talking about a determinant frameworks. Determinants frameworks include the CFIR. Here we can see Enola Proctor's conceptual model of implementation research, which highlighted the critical importance of implementation strategies. Whereas traditional research considers the intervention strategies and the client outcomes, implementation research is invested in teasing out that black box of implementation strategies and how they facilitate implementation outcomes, service outcomes, and ultimately patient outcomes. Laura Damschroeder and her team noted around the millennium that interventions often fail to translate into meaningful outcomes across contexts. She and her colleagues conducted a massive literature review of models, theories, and frameworks that resulted in the creation of a meta-theory called the CFIR. There are 5 major domains: the intervention, the outer setting, the inner setting, the individuals involved, and the implementation process. So by taking stock of the broader picture of where implementation strategies are introduced and the varying impact of the inner setting, the individual stakeholders interacting with implementation strategy, the broader outer setting, the intervention itself, and the process by which it's actually implemented, one gets a more holistic and nuanced understanding of the drivers of implementation success and failure at the facility level. As these constructs and domains are considered, the intervention itself on the left is adapted and refined to that on the right. You can see on the left how it's kind of just sort of out of the lines and a little bit messy. And then to the right, once all these other elements have been considered, you can see how it's been adapted, including its core components and the adaptable periphery. So each domain contains specific constructs. For intervention, we have intervention source, its evidence strength and quality, its relative advantage, adaptability, trialability, complexity, design quality and packaging, and cost. For the outer setting, we consider patient needs and resources, its cosmopolitanism, its peer pressure, its relation to external policies and incentives. In the inner setting, we look at structural characteristics, networks, and communication, the culture of the inner setting, typically a facility, right? Implementation climate also includes 6 sub-constructs: tension for change, compatibility, relative priority, organizational incentives and rewards, goals and feedback and learning climate, and readiness for implementation, with another 3 sub-constructs: leadership engagement, available resources, ding, 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 access to knowledge and information. Individuals is the 4th domain of the CFIR. What are their knowledge and beliefs about the intervention? How self-efficacious are they? What is their individual state stage of change, and what is their personal identification with organizations, and any other personal attributes. Finally, the process includes planning, engaging with opinion leaders, formally appointed internal implementation leaders, champions, external change agents, reflection, and evaluation. So generally, when you use the CFIR, you do not attempt to capture all the information. You do not attempt to capture information on all the constructs or even all the domains. Rather, you consider your intervention and the sites where you will be implementing, and then based on formative research and input from stakeholders, determine which deductive constructs and domains will likely be most influential on the implementation strategy and intervention success or failure. So then you can use the CFIR interview guideline tools. You can see the link up above. And you can generate draft questions to then adapt and then pilot in your sites and then refine. So when do we use the CFIR? You can use CFIR a lot of different places. Today, we're going to talk mostly on the back end, but you can use the CFIR before the development of an intervention, and you can use sort of formative research to obtain systems level information to feed into the development of a future implementation study. Also to develop tools and so forth and questionnaire guides. During the implementation of an intervention, it can also be used. This can enhance the likelihood of success through analysis, barriers and facilitators, or to optimize and improve a current situation. And finally, you can use it after implementation to assess the process across sites, right? So that retrospective evaluation can provide hypotheses to explain why things succeeded or failed during implementation, or if there was any effectiveness heterogeneity across sites. So it's used when you need more detail to understand and measure implementation efforts. And these are critical. In implementation science, we're really trying to come up with strategies to make things work better. So in order to do that, we need to also think about how do they work better at scale. We often say implementation science is the science of the no-do gap. I would argue that it's also the science of going to scale. And so how do we take what we learn and how do we apply this to moving to the next level? So in light of this, I'm going to give a few slides on the case study of the 2019-2024 Systems Analysis and Improvement to Optimize the Hypertension Treatment and Care Cascade for HIV-Infected Individuals, or the SCI-HTN trial in central Mozambique, which I lead. So, using a 3-year pragmatic parallel cluster randomized control design, we are prospectively implementing SCI-HTN and evaluating its impact for HIV-infected individuals in 8 intervention and 8 control facilities in central Mozambique. We've included a 2-year intensive phase that will be we'll be finishing up in about 6 months. And a follow-on 1-year sustainment phase to assess the impact of the SCI-HTN with and without intensive support from study nurses, which will provide evidence on the intervention's impact under ideal circumstances, as well as the longevity of its effect over time. We have 3 main aims to determine the effectiveness of SCI-HTN on the HTN cascade optimization for HIV-infected individuals. Number 3, we're also going to look at the cost and cost effectiveness, but what we're going to focus on today is how we use the CFIR, which is primarily in aim 2, where we're trying to determine the drivers of SCI-HTN intervention implementation heterogeneity across facilities. So we use the CFIR as well as some other tools that I'll discuss very briefly. We include both process and clinical outcomes, and we have both urban and peri-urban sites. So monthly, just to give you a little background on what is the SCI hypertension intervention, these are the steps that we carry out monthly with our frontline healthcare team. We use routine data and populate a hypertension cascade analysis tool that you see on your left. It allows us to see what the drop-off is across the steps of consults, screening, medication prescription, medication pickup, and controlled hypertension. We also use process mapping with a team where we map out not the processes of how services are delivered, but rather how patients flow through our services. So what is it like for the patient as they come through our services, and where are the obvious bottlenecks? So those two tools, the CAT and the process mapping, help the team come together and unify on what it is they're actually doing, and then be able to step back and prioritize where they should be focusing their efforts. So those two tools then build onto the third systems engineering intervention, which is continuous quality improvement, where they can plan, do, study, act with a little more knowledge, collective knowledge under their belt. So these are the steps that we look at. We analyze losses to follow up along the hypertension cascade for people living with HIV. We map the flow of HIV positive patients through hypertension services. We define and implement facility-specific changes to eliminate the modifiable bottlenecks in continuous quality improvement. And we likewise monitor via routine performance data. And this is repeated again monthly with the healthcare team. Our evaluation of SIA-HTN to optimize hypertension among people living with AIDS using CFIR. So how do we do this? So we use a CFIR guided qualitative evaluation of SIA hypertension implementation in both high and low performing sites. So when I say high and low performance, performance is determined by fidelity to the SIA-HTN intervention. Are they actually doing all those steps monthly? And we use this to identify the determinants of intervention success and failure, and identify core and adaptable SI hypertension components. Remember, in implementation science in general, and particularly when you're using the results to inform future scaling, you need to exploit heterogeneity. When sites are different, they have different resources, they have different cultures, spaces, materials, practices, etc. This is a good thing. This needs to be detailed, and outcomes need to be presented in such a way that we can share with stakeholders. For example, what works in small sites is this, and what works in busy urban sites are that. And overall, this is what needs to be present in every single site. We also, for this component, are using the ORIC, the Organizational Readiness for Implementing Change, initially, and then health facility surveys annually to identify drivers of implementation readiness at the facility level. And finally, we're also tracking implementation fidelity or dose at the facility level. So these are just some of the other approaches that we're using in addition to the CFIR. The top left is a guide to measure implementation fidelity through dose, including not just the quantity of the intervention delivered, but also the quality provided. On the bottom left, you can see a shortened version of a health facility assessment, which we track in all sites annually to understand and measure the structural readiness of study sites. Finally, on the right, we're also using the Organizational Readiness for Implementing Change from Brian Weiner, generally administered to health facility staff within the first 3 months of beginning the SIA hypertension to determine their readiness to implement this new implementation strategy. Our use of the CFIR in the study was informed by an earlier pilot that helped us identify the constructs of interest, right? So you can see here to the right which of the constructs we decided to focus on. And you can see that some of them we'll be collecting through more qualitative approaches, and some of them is through via more quantitative monitoring and so forth. Our data sources include focus group discussions at the intervention facilities and in-depth interviews with facility and district managers, both at the end line and after the maintenance phase. Also, we'll be using routine monitoring and field notes. Actually, we are. Our approach is qualitative content analysis with 2 coders per transcript. We individually code and then work together to resolve differences. Then we refine case memos together in pairs, and we have 3 analysts work to assign the final ratings for each facility. In general, this is a deductive process, but we're flexible for new themes to emerge more inductively. The rating My rating approach has been described previously, which I've adapted from Laura Damschroeder. In brief, it's a rating process that reflects the positive or negative influence or the valence of a particular construct and the strength of each construct. And the constructs are coded as missing too much data, not available, weakly 1+, 1-, or strongly 2+, 2-, and distinguishing low or high performance. So we use these findings to develop recommendations for this eye hypertension implementation. And we can also extrapolate that to include discussions on what are the core components, what are the intervention adaptations, adaptability, and what are the lessons learned. So our guidance for scaling, we're exploring results. What we take from doing CFIR work, we can use to adapt and understand our current findings, but we can also use them to understand where we'll be going. So we can explore results across heterogeneous sites and look at grouping sites by performance fidelity to understand why certain sites respond in some ways and certain sites respond in another way. We can also look for core and adaptable components of implementation by looking at commonalities and differences via our discussions with the end users. But I think also what are the essential components of this strategy itself across all sites is something that you have to really keep a hold of. We found in most of our SIAS sites, at least 3 components are critical, but we have seen some variations in some settings around the periodicity of one or the other of the 3 main systems engineering tools that are used within the SIA. So providing, I just want to close, providing with a synthesized, contextualized implementation guidance to stakeholders to effectively implement evidence-based interventions and bring them to scale is crucial to bridge the global no-do gap in chronic disease. The CFIR, a determinants-based implementation framework, is one effective tool used to achieve this. So I hope that was helpful today. Thank you very much.